Thank you for joining us this afternoon. My name is Kate Astor and I am the Sales and Marketing Manager at Nephros. I am joined today by my colleague Shane Sullivan and of course our speaker Tim Keane. Tim is a consulting engineer with Legionella Risk Management and is an internationally recognized expert on methods to control the risk of Legionella in building water system design and operation and mitigating issues. He has 40 years of field engineering experience, including new construction project engineering, facility engineering, water treatment consulting, and the last 20 years focused on building water system design, operation, maintenance, and code development for waterborne pathogen mitigation and control. We are so fortunate to have him with us here today to help us prepare for what Legionella outbreaks may look like current day and how we can best prepare our facilities.
Kate, I'd like to thank you and Shane and Nephros for hosting this webinar. I'd like to start off with going over the fact that Legionnaire's disease is constantly rising year after year, and it is creating quite a bit of a concern on the increased rates of illness. I think one slide that really tells it very well is this from CDC that shows prior to 2000, very few cases of Legionnaire's disease. In a lot of cases, the top portion of the bar with the crosshatched is unidentified. Then in 2005, you can see the bottom of the bars in black, that's Legionella. Outbreaks in domestic water systems are increasing greatly. And now, in 2009, Legionnaire's disease-related water outbreaks, more than 50% are Legionella. So Legionella has come it surpassed number one into the topmost disease responsible for domestic water outbreaks. 25,000 estimated cases annually of Legionnaire's disease. 80% of those cases frequently are not identified. OSHA estimates the number to be twice as high at 50,000. What's really interesting is many people think Legionnaire's disease is a disease of the sick and ill and infirm in healthcare facilities. When you look at the breakdown, less than a quarter of Legionnaire's disease outbreaks are associated with healthcare. That's hospitals and nursing homes combined. A greater percent, a slightly greater percent, 24%, is associated with hotels, and 53% of all outbreaks are associated with unknown origin. For this webinar, what's really pertinent is the fact that 25% of all Legionnaire's disease outbreaks are estimated to occur in buildings within 1 year of construction and renovation, many of those within the first few weeks of operation. Because of this, ASHRAE 188 implemented a section on commissioning that says disinfection and flushing shall be completed within 3 weeks prior to whole or partial beneficial occupancy. So ASHRAE 188 realize the significance of building water systems that are sitting stagnant for a prolonged period of time, as is commonplace in new construction or renovation. In new construction, the plumbing systems are typically one of the first items completed in the shell of the building, and then electrical is run and finishing is done, and typically plumbing is completed anywhere from 3 months to 6 months prior to occupancy. So that 25% of all outbreaks associated with new construction has a lot to do with the fact that typically these buildings sat dormant and were not disinfected. ASHRAE 188 hopefully will address that key issue, and those numbers will go down greatly. Part two, I'd like to talk about case studies, outbreaks of Legionnaire's disease. One very telling outbreak was written in an ITCHE article, a peer-reviewed publication titled An Outbreak of Legionnaire's Disease associated with a decorative water wall fountain in a hospital. When I read this paper, I saw a lot of issues, a lot of items that did not add up to me. So I wrote the author of the paper with these questions, and I received a very nice reply. That reply states, "We agree that the engineering aspects of these investigations tend to take a back seat to the medical or epidemiological features in most reports published in medical literature. This is likely because of the nature of the journals in which the reports are published, the constraints on manuscript length, and the fact that investigating agencies typically have considerably more expertise in medicine and epidemiology than they do in environmental engineering." This is an all too pervasive issue with published literature related to Legionella and Legionnaire's disease, because Legionnaire's disease is a disease of plumbing systems. When public health or others without a significant understanding of the engineering concepts related to building water system design, operation, and maintenance, they frequently draw poor conclusions based on their lack of understanding. A good example of this is VA Directive 2009, probably one of the best Legionella standards ever written. This was required in all VA hospitals from 2009 through 2014. It required hospitals to be maintain 140 degrees in their hot water storage tanks, required a master thermostatic mixing valve to bring the temperature from 140 down to 130 before being discharged to the building hot water circulating system. And then it required 120 to 130 degrees at all sinks and showers. That was a very effective, very simple, very cost-effective protocol for controlling Legionella, and it worked extremely well. I audited several VA hospitals, 2011 and 2012. All of the hospitals I audited were in compliance with this standard directive, and none of them had any issues in their infection control logs of scalding related to these higher temperatures. And a significant portion of the residents and patients in these hospitals are elderly. The issue was in 2011-12, there was an outbreak at a VA hospital in Pittsburgh, PA. 21 cases of disease, and 5 of those resulted in death. The outbreak occurred in a hospital with a very long, significant history of documented Legionnaire's disease cases over decades. The issue here was the conclusions drawn based on the investigations were incorrect. The conclusion was that the 2009 directive failed, but in fact, at the time of the 2012 outbreak, VA Pittsburgh was not in compliance with the 2009 directive. Hot water heaters were not set at 140 degrees. Master mixing valves were not installed on any heater, and the water was not distributed between 120 to 130 degrees. It was typically being circulated at less than 115 degrees. As a result of this, VA changed their policy in 2014 and implemented one of the most expensive protocols that has had significant issues. Another good example of problems in identifying and resolving issues is the Quincy Veterans Home. They had an initial outbreak in 2015, resulting in 46 cases of illness. CDC investigated in September of 2015 and wrote a report. They had a second outbreak in 2016 with 5 additional cases. CDC investigated in August of 2016. 2017, they had a third case with 6 cases, and CDC investigated and wrote a report in December of 17. And finally, in 2018, in February, they had 3 additional cases. So 4 outbreaks in less than 3.5 years, with a total of 60 cases. In 2016, 17, and 18, they had at the Quincy Veterans Home a water management plan in place that had been reviewed and approved by CDC. In fact, in the January 2018 CDC report, they wrote, the Department of Public Health and the Illinois Veterans Home at Quincy staff have committed substantial time, effort, and resources to achieving control of Legionella growth at the Illinois Veterans Home in Quincy through effective water management, including the installation of a supplemental disinfection system. So this is after 2 outbreaks with a water management plan in place. CDC called the plan effective. And after the 3rd outbreak with a water management plan in place, CDC wrote in their 2018 report, despite considerable time, effort, and resources committed to achieving an optimal water management plan, there continues to be Legionella growth and cases of Legionnaires disease, likely attributable to plumbing age, materials, and resident population characteristics. The cost of this was astronomical. 2015, over $6.5 million was spent on improving the hot water system, which was a justified and good expense. Between 2015 and 2018, another $30 million was spent, much of that because of issues in the water management plan not delivering the desired results. And then in 2018, $230 million was dedicated to rebuilding the systems because the CDC report in 2018 recommended an option of demolishing the buildings to resolve the issue. This was the first time that to get rid of Legionella, a U.S. nursing home is planned to be demolished. Multiple errors were made here, as with VA Directive 1061, which was published in 2014. Hot water was circulated at greater than 130 degrees. Master mixing valves were not installed. If you recall earlier, they were required in the 2009 directive, but in the 2014, they were not. And point of use mixing valves were installed at each sink at a huge install and operational cost. Again, these were not required and necessary in the 2009 directive. They were added in the 2014, which added extensive costs and maintenance requirements. Also, the wrong disinfectant was used for the application. Had the state increased nursing home temperature to 120, the amount of illness, even with all these issues, would have dropped dramatically. Finally, in June of 18, we were on our way to resolving the issues. I had proposed a solution to the long-term issue to the state. The proposal was accepted, a contract was initiated, and in August of 2018, myself and Virginia Tech teams were on site to review our proposed solutions, audit the systems, and determine next steps. December of 2018, we implemented 2 of our recommended steps. We changed the disinfectant type and we changed the automated mains flushing program. Fixture flushing was reduced from 3 times a day to once a day. That was huge. Every sink and every shower in the nursing home was being flushed 3 times a day at a tremendous annoyance to the patients, tremendous amount of time to the staff. And Legionella levels, once these changes were implemented, improved immediately, and costs were a small fraction of the previous actions. So all these case studies kind of relate back to that initial comment on the ornamental fountain. The fact that investigating agencies typically have considerably more expertise in medicine and epidemiology than they do environmental engineering results in frequently costs that are astronomically high and frequently don't resolve the issues and result in additional cases. Very pertinent to the discussion here, the COVID and the building water sitting idle during the COVID period was a paper I gave in 2012 at the AWWA Water Quality Technology Conference in Toronto. And the paper was about case studies I was involved in of Legionnaire's disease outbreaks that were related directly to municipal water disruptions. One of the first slides was it's been well established in guidelines and papers that municipal water disruptions pose a significant risk for Legionnaire's disease outbreaks. However, there's no detailed case studies on these types of outbreaks. This paper will present case studies of 4 Legionnaire's disease outbreaks in which the author was directly involved. And those 4 outbreaks were one in 2006 at a hospital where a backhoe went through a water main. The water coming into the building became dirty immediately. And within 3 weeks, they had a large outbreak of Legionnaire's disease, 2 deaths and 10 illnesses. In 2009, an elderly apartment complex, after a planned municipal water pipe rehab right outside the complex, when the rehabbed pipe was put back online, within a month, they had a large outbreak with 1 death and 10 illnesses. 2008, an elderly apartment that had a water main break in the street adjacent to the apartment complex, 2 dead and 11 ill immediately within 30 days. And then there were another 15 that got ill within the next 30 days. And in 2004, a long-term care facility that had 2 mains. It was in between 2 municipalities. When one municipality's pressure went down, the system automatically switched to the other that had not been flushed. The turbid water came into the building, and they had an outbreak within 2 weeks, 1 death and 12 sick. Typically, onset of illness after exposure to Legionnaire's disease is anywhere from 2 to 14 days, but because of the high concentration of bacteria in all these cases, the outbreaks occurred very shortly after the event. So now let's get into some of the specifics regarding the issue we're concerned about today, and that's dramatic water use reductions and stagnant building water systems. CDC published a report related to this titled Guidance for Reopening Buildings After Prolonged Shutdown or Reduced Operation. Included in that document is this statement: when water is stagnant, hot water temperatures can decrease to the Legionella growth range of 77 to 108 degrees. That is an incorrect statement. That is actually the high growth range. The growth range for Legionella, and this is really important, is shown in the IAPMO UPC code published just a few months ago in Appendix N. That lists the low range for Legionella growth as 77 to 85. So in that range, it will grow slowly. Between 85 to 110, it will grow quickly. It will still grow above 110. So moderate growth of Legionella is between 110 to 120. Above 120, it typically does not grow, and above 130, it dies quickly. So this is real important information. If you have a building that's been sitting stagnant for a prolonged period of time, and you're concerned about biofilm and bacteria growth, increasing temperature to 110 will do nothing, will not kill the bacteria, and it will still be growing at that temperature. So you really need to get the temperature above the 120 level at all fixtures for the temperature to control the Legionella. A lot of people think 110 and above is a scalding risk because that number occurs in a lot of plumbing code. That is not in plumbing code for scalding purposes at all. The 110 number came from a 1989 ASHRAE 90.1 standard for energy savings in buildings. And in that standard is two of the big issues associated with Legionnaire's disease today. Public restroom requirement of, as you see at the bottom of the slide, temperature limited to 110 degrees Fahrenheit, and at the top of the slide, flow limited to a maximum of 0.5 GPM. Probably no two better things you can do to culture and incubate Legionella than have the right temperature and near stagnant flow conditions. So this is one of the high risks out there. And then on top of that, many of these laboratories have electronic faucets, a very complex component with a lot of surface area that further increases the risk. So 110 is not a scalding issue. As a matter of fact, in all of the elderly apartment complexes I've been involved in resolving outbreaks, they are all maintaining 120 to 130 in their sinks, and none of them have had any complaints of scalding. There is a lot of health department documents that had been published regarding COVID building startup. There's now over 60 documents giving instruction and guidance. Many of them are written by those same health department people we talked about in the earlier slide that lack the engineering expertise. So some of them are very light in direction, such as at far right CDC, which basically gives no direction other than establishing a water management plan. To the far left, you see the state of Washington. The state of Washington actually has engineers in their health department that help develop this very good document. EPA put out a very useful and very important document titled Maintaining or Restoring Water Quality in Buildings with Low or No Use. Included in that document, addressed to municipal water suppliers, is the following statements: coordinate distribution flushing activities with nearby building owners and managers. So EPA is telling the municipal water suppliers, make sure when these buildings start up and you go out to flush your hydrants and mains, that you do so coordinated with the building owners, so when they are flushing their buildings, they're getting fresh water and not old stale water that may have bacterial problems. And the second bullet, be prepared to provide information on system disinfection activities or proactively post information on the utility's website, such as type of disinfectant used, residual maintained, and scheduled free chlorine periods for systems using chloramine. That's really important. Chloramine has been documented to be an extremely effective control for Legionella. The problem with chloramine, though, is it's free chlorine stabilized with ammonia. And when that chloramine is sitting stagnant in mains or distribution systems, what can happen there is that chloramine can break down, and instead of just going away, it can break down into no chlorine, no disinfectant, and either ammonia or nitrate, which is bug food. So the problem with chloramine is you can actually increase the potential for bacteria growth when it's sitting in the system stagnant. In my document, Chapter 3, Developing a Building Potable Water System Flushing Program, there's a whole section on contacting the municipal suppliers, collecting municipal supplier information from websites, and hydrant flushing. So make sure you go through that document because it is very informative. And that document can be found on my website as shown here. AWWA had an excellent webinar titled Returning to Service, Addressing Water Quality in Buildings with Low or No Use. And in that webinar given by Alex Margavakis, there were 3 slides that were extremely pertinent to the discussion here. You can see this one slide where the municipality had gotten information on electronically from all their customers on water demand and water demand change. And you can see this shows the impact. Water usage down 62% at a stadium, 78% at a shopping center, 87% at a mall, 99% at a high school. This map even shows the information much better. You can see the downtown area, a huge cluster of water use that has dropped off dramatically. So not only are those buildings stagnant, but if not flushed by the city, those mains in that downtown area, the University Circle, the college, the mall area, the office park area, all are stagnant as well. Cleveland went and also contacted all these users with extreme reductions in water usage to let them know about the risk as recommended by EPA in their document. So knowing all this, what should building owners be doing now? We got dramatic water use reductions, building water stagnation. CDC, as I mentioned, only recommends developing a comprehensive water management program. The key steps in ASHRAE 188 to a water management program are develop a team, describe the building water systems, develop process flow diagrams. 3, analyze building water system hazards. 4, define control measures, locations, and limits. 5, conduct routine monitoring to verify controls. 6, validate program control. And 7, document the plan is implemented. And frequently in developing these plans, a lot of people may be involved. Not all these people, depending on your building type, but epidemiologists, health and safety, infection control, public health, microbiologists, certified industrial hygienists, academic researchers, applied engineers, registered plumbing professionals, mechanical contractors, consulting engineers, plant operators, maintenance personnel, building owners, managers, designees, housekeeping, salesmen. There can be a whole slew of people that are involved for one reason or other in developing this plan. But short term, I don't think you really need a plan, but you need to focus on certain things to make sure the risk is controlled prior to occupancy. Describe the building water systems and understand them is extremely important. An engineering analysis of the building water system hazards is very important. Defining control measures, control locations, and control limits, and also validating the program, testing and making sure the Legionella is not there. Specific steps that can be taken to do those items are 1, an engineering audit of the building water systems. 2, flushing the building water system. 3, disinfecting the building water system as needed. 4, defining the controls and control limits. 5, validate the controls, testing for Legionella, and plan for if you have positive results after flushing, either disinfecting again or adding filtering at point of use. 6, consider communications if the building's occupied on how you're going to make the occupants aware of the issues. And 7, ensure proper safety protocols are implemented. As I mentioned earlier, a lot of these items are discussed in detail in my document, Chapter 3, Developing a Building Potable Water System Flushing Plan. It includes when and what to consider for flushing and disinfection, short-term, moderate-term, or long-term stagnant conditions. It includes a warning section on risk factors for Legionnaires disease, for Legionella transmission, aerosol risk transmission, and Legionella growth in buildings. There's a whole section on preparation that we discussed earlier, and then a whole section on disinfection. Basically all the how-tos to disinfecting a building potable water system. But if you require disinfection, I do recommend you contract a local contractor with expertise in that, and you can use this document as a specification for what needs to be done. An example of items included in the document is for small hot water systems. It says potable water systems and buildings with small, uncirculated, no hot water return pump, hot water systems likely do not fall under the requirements of ASHRAE 188 to have a Legionella risk management plan. Buildings with small, uncirculated hot water systems may include restaurants, stores, small office buildings, dentist office. Many of the buildings, for instance, in a university campus, have very small hot water systems, and then dorms and some of the big buildings will have large hot water systems. But these smaller systems are much easier to flush and address waterborne pathogen issues. In these systems, maintaining water temperature at greater than 120 degrees at all fixtures and greater than 140 in storage tanks is an effective method for reducing risk from Legionella that is relatively simple to implement. And as I mentioned below, even if compliance with ASHRAE 188 is not required, an engineering audit of water systems is recommended. So who should be doing this audit? Well, that whole group of people developing the plan is absolutely not necessary to audit building water systems, develop flushing plans, and control programs. My recommendation is those with engineering competence, such as academic research engineers with applied experience, registered plumbing professionals, mechanical contractors, consulting engineers, and in some cases, the building itself may have plant operators and maintenance personnel capable of doing this. In the book Epidemiology with Student Consult, written by Leon Gordis, it says rational policies should be adopted for preventing disease and enhancing the health of populations at the lowest possible cost, is the definition of good public health policy. One of the issues we have is when people don't understand in public health the systems that they're looking at, they can come up with solutions that don't result in good public health outcomes and do so at the highest possible cost, as was the case at the Quincy Veterans Home and at the Veterans Facility in Pittsburgh. I received this quote just a few days ago from a public health association I belong to that seemed very apt. Nothing in the world is more dangerous than sincere ignorance and conscientious stupidity, from Dr. Martin Luther King Jr. So knowing the systems, having the competent engineering background to understand the systems is, in my experience, the absolute most important thing to identifying, resolving, and minimizing Legionella risk associated with building water systems. Thank you very much, Kate. That's all I have.
Great. So Tim, we do have a couple of questions that I just want to go through. The first being, how long are facilities typically under observation after a patient event?
After an outbreak, the observation period can fluctuate. Typically, it's a year after all of the issues are resolved. Sometime that period can be shortened. So depending on who you're working with, if it's county health, state health, or CDC, depending on the severity of the problem, on the amount of illness, and the responsiveness to the facility, in some cases, I've seen monitoring limited to 3 months after the outbreak, but typically on significant outbreaks, the health department will want a year's worth of data and testing to validate that the controls worked and the people are safe.
Great. And the last question we have is, although Legionella is clearly the focus and headline, should water management plans address other waterborne pathogens, such as Pseudomonas, if there are high-risk areas in the building like INCUs and burn units?
That's a really good question. I've talked to several people about that. CMS has come out with a requirement that healthcare facilities have a waterborne pathogen plan in place to control Legionella and these other pathogens. But in that document, CMS does not recommend testing for any pathogens, which I think is a mistake. I wish CMS would change that and recommend testing for Legionella to validate that the controls work. But they don't recommend testing for any of these other pathogens. And one of the issues is we don't have a lot of data on these other pathogens. There have been papers written, though, that says maintaining the temperature at temperatures for Legionella will control these other pathogens. So the thought is that controlling Legionella will control these other pathogens. I mentioned earlier concerns with chloramine, that when it breaks down, it can release ammonia and nitrogen into the system, which is basically bacteria food. But one of the other issues with chloramine is, even though it's very good for Legionella, it has been documented to have issues with controlling Pseudomonas and mycobacteria. So if you've got a municipal supply that is using chloramine as a disinfectant, and your building's been stagnant, you may have potential for these other pathogens to grow significantly. And expectations are that having the controls for Legionella should control these pathogens. It would not be a bad idea to do some tests for Pseudomonas and or mycobacteria to confirm that. The problem with mycobacteria is it's a very, very slow-growing bacteria, where Legionella takes 2 weeks to incubate in a culture test in a lab. Mycobacteria takes a month.